name is Ricardo Hatfield, and today we'll be going through my Assessment 1 audio-visual task, working through the metabolic syndrome case, which is also commonly known as METS. So the client we'll be working with is a 54-year-old woman named Paula, who has been referred by a primary care physician for initial exercise physiology consultation, primarily for metabolic syndrome and cardiovascular risk reduction. Paula has a family history of heart disease where her father had a non-fatal myocardial infarction at 55, which is in fact identified as a red flag. Her extremely high BMI puts her in the higher ends of the obese category. She reports being completely sedentary at work and at home and has no history of physical activity or exercise within the last 5 years, which will also greatly contribute to her condition. She's a regular smoker and she says she's not interested in quitting. She's also been diagnosed with depression and reports days where she does not feel like getting out of bed. Now, as research shows, depression is a common comorbidity of METS also. Her medications include 500 milligrams of Avapro a day, an ARB that can present with dizziness and fatigue, 20 milligrams of Lipitor a day for the last 6 months to lower cholesterol, which she reports muscle aches in her body when she does things like hang clothes on the line or walk upstairs. Common side effects also. And sertraline 50 milligrams a day for her depression. Currently, her gold standard is using exercise to improve cardiovascular risk factors and no longer take sertraline. Also, she expresses to us that she's happy to come to the clinic 3 times a week with only TheraBand and Swiss Ball available at home with no access to a gym, and is only available in early mornings due to her work. And finally, she's mentioned in relation to exercise that she liked walking in the past when she was younger, but stopped due to work commitments, family, and other factors. Okay, continuing on from this, a little background information on METS itself, what it can present as, plus its concerns. So firstly, METS is a collection of conditions that may accumulate due to unhealthy living and are all independently risk factors for cardiovascular disease. We see this displayed in METS cases as high central or abdominal obesity, high blood pressure, high triglycerides, lower HDL cholesterol levels, and also high insulin resistance. This means that alongside presumably low exercise tolerance, patients also run the risk of developing type 2 diabetes due to this cluster of factors, suggesting even greater difficulty with exercise and requires closer monitoring of blood glucose levels and fatigue. Also, quite commonly, CVD such as stroke and heart disease can occur due to formation of atherosclerotic plaques forming across decades of poor living, suggesting as to why interventions can be crucial in preventing a medical event. And finally, upon further development of the disease, we see gout and PCOS, also known as polycystic ovarian syndrome, become a real possibility for Paula. So gout as a result of METS is an extremely painful condition involving greater inflammation of the joints, often seen starting at the feet in the big toe. From here, exercise can become increasingly difficult, eliminating activities requiring weight bearing on the feet. And PCOS, as a result of METS, also seeing hormone imbalances, creating a range of serious issues, but primarily sees enlarged ovaries enveloped by small cysts. So in conclusion, all of these factors discussed present great reasoning as to why physical activity intervention should be so important for our client Paula in improving her overall condition and limit greater health complications leading to progression of disease. Moving on, taking a look at some of Paula's results and what they mean, starting with her physical examination on the left, we see a resting blood pressure of 140/90, which classifies her as a stage 2 hypertension according to AHA. Looking at some client and practitioner goals now, basing off what the client has expressed and what I believe as an EP should be appropriate at each time point. So starting with the clients in short term, Paula would like to quite broadly be more active, less sedentary, feel happier and feel more energetic. In the medium term, she'd like to slowly begin to lose weight, which would be suggestive more towards the end of this period. feel better and lessening of sertraline dose as approved by her GP, and have improved CVD risk factors such as blood pressure, HDLs, blood glucose levels, and insulin resistance. And long term, the 5 clustering conditions much closer to healthier ranges as per guidelines. 5 to 10% drop in body weight at this point, which is appropriate and safe, and limiting to smaller doses of prescriptions whilst being able to be completely off sertraline, all of which can only be completed upon GP reassessment and provided it is safe to do so. And to my goals now as a practitioner, which build off Paula's but seek to be more specific and more importantly evidence-based. So short term, I would like to slowly build up to exercising tolerance 5 times a week at lower intensities as per recommendations, with the idea of just getting her moving. And due to her very limited physical activity history, it wouldn't be possible to jump straight to this, so it would be a build-up. Also to establish a daily routine from exercise to walking, eating times, work and home duties, and so on. So really just getting some consistency and hoping to eliminate days where she doesn't want to get out of bed. Break up prolonged periods of sitting at home and work, and seeing some improvements in mental health via exercise, which will be somewhat guided by the questionnaire. In the medium term, we'd ideally start noticing small changes in waist circumference towards the end of this period rather than a focus on weight loss itself. Also propose a GP reassessment on her medications, seeing what can be reduced, have outcome measures and list improved biological markers to do with CVD risk factors, and as per end program retesting to see an improved VO2 peak score, leaning more towards healthier ranges for her age and sex. And finally, long term, seeing conditions even closer to healthier ranges or within healthier ranges, and therefore medications less reliant on or not needed as approved by GP reassessment or psychological evaluations. We can obviously only be done with vast improvements in mental health and physical health via these outcome measures. And ultimately see Paula independently make lifestyle changes, so seeing things such as seeking out mental health advice, making better dietary choices, or even stop or limit smoking, all of which are things that can only be done provided good client education has been given across the duration of the intervention, and a strong sense of motivation is installed within the client to continue on a lifelong path of better health. Okay, and for outcome measures that I like to complete with Paula alongside some of the ones that we have already gone through on previous slides include a waist circumference and waist to hip ratio test. This is something that will be more of a focus rather than strictly weight, seeing that central obesity is beginning to improve, one of the clustering factors of METs. Also noting that it can in fact be normal for weight fluctuations to occur during a newly commenced program. Therefore, abdominal obesity will be more important, and as per research demonstrates its validity and reliability determining further CVD risk. Secondly, the SF36 questionnaire will be administered to determine quality of life and mood for this individual who is suffering with depression and METs, therefore seeing how exercise has helped and where they are currently is important. It should be noted though, for a complete psychological evaluation of depression, this is outside an EP scope and therefore will be referred on to do so. And finally, strength and endurance testing of 30-second sit to stand, 30-second wall push-up, and 30-second unit lateral bicep curl tests provide useful information on determining prescription or resistance training for Paula. It is also specific enough in bilateral and unilateral movements, remains functionally focused, and is appropriate to her level as she elicits not exercising at all for the past 5 years. Okay, so here we have the first session of week 1 of the program, starting with a continuous walk followed by dynamic stretching lasting around 10 minutes. Shown by research to be most effective in elevating heart rate, increasing muscle temperature and blood flow, ready for clients in this population to safely commence exercise. And ending it with a cool down of roughly 6 to 8 minutes with a continuous low intensity walk broken up intermittently with whole body static stretching. Again, important to slowly return the body's responses to exercise to more resting levels and limit muscle soreness, important due to a prescription of Lipitor. For the main part of the session, I have commenced with a continuous low intensity recumbent bike for 10 minutes
targeting the METS condition as recommended per guidelines until fitness is increased. And is important for severity of depressive symptoms, again, as shown by research. Intensities and duration also prescribed accordingly under METS guidelines and for total duration of the session also. And current fitness levels as per outcome measures also. Then moving on to resistance, exercise for upper, lower body and trunk muscles have been chosen, keeping movements fairly functional, also opting for lower intensities and higher repetitions recommended by research until an adequate level of strength is attained, with rest periods similar to general population. And exercise is created quite simple due to her lack of physical activity experience, yet still allows work of larger muscle groups. Okay, so upon designing the program, we see that some unexpected situations occur with Paula, and during the intervention, her blood pressure starts dropping after each exercise session from quite a high peak value down to 130/70, causing her dizziness. And also the patient is enjoying the program, but is starting to find attending the clinic 3 times a week too much. So for both of these situations, we'll go into greater detail on how they were dealt with on the next slide. And finally, Paula usually comes to see me for a morning appointment. However, on session 6, she's unable to attend her usual appointment and instead attends in the afternoon. Her resting blood pressure is 190/90, and she reports having fish and chips that day for lunch. So on this day, I chose to monitor her for the hour of that session and not exercise her whatsoever. It is extremely high and it would not be safe to do so. So in the case her blood pressure continues to rise or a medical event occurs, I'll be calling 000 immediately. If not, I would still ensure she's monitored for the rest of the day for future sessions. BP will always be checked and monitored with meals that day asked. Okay, now here we are looking at the same session, but in the final week, 12 weeks later, shown to be effective in greatest health outcomes with programs of this duration. But it's one of the originally 3, but now 2 clinic sessions, which we've altered due to finding 3 too much. The other actions we've taken is to then replace this with extra 20-minute walks weekly, shown in greater detail in the Word document. Furthermore, walking has been shown to be one of the most effective modalities for METS patients and individuals suffering with depression, suggesting as to why it was implemented over other exercise. Okay, now for progressions, we can see below that for aerobic, the intensities of each 5-minute period have increased, but the duration has not, still overall lasting 10 minutes. These progressions have been implemented to increase cardiovascular fitness, and if done correctly, should increase upon the baseline VO2 peak that was recorded, subsequently improving the 5 clustering conditions of METS. For resistance, exercises have progressed in difficulty either due to challenging greater motor control or requiring greater muscular activation and force. In cases that they have not changed, these have also been progressed, but through increased repetitions, sets, and or intensities, but have still remained within the guidelines for METS patients and have been set accordingly to the client's results in outcome measures at baseline and at mid-program. And conclusively, in reference to the exercise-induced hypotension occurring with Paula, we've now implemented a low-intensity 10-minute cool-down walk without the stretching intermittently, but rather at the end separately. In this 10 minutes, it is recommended by ACM to monitor blood pressure until much closer to pre-exercise levels. And if achieved, we'll then finish up with these static stretches. This is found necessary for the safety of the client whilst in our duty of care. And for the last 2 slides, we have references used throughout and also the links to the images used here. Thank you for watching.